Other than that, can you hear me?
Mhm.
Weeks. Hey everybody, can everybody hear me? Good, great. So we're going to go ahead and get started right on time. We have a couple of things to get to. I know we have some more people joining us here, but also joining virtually as well. But we'll start with introductions real quick, and then we will move on to we have two cases, and then we have some other questions. And if anybody else has any cases to bring up impromptuly, I don't know, we can totally do that. So let's see. Greg, do you mind to start introductions for us?
I'm Gregory Peters. I'm a family medicine doctor with Community Care of West Virginia in Buchanan.
Perfect, thank you. All right, and Carmen?
I'm Carmen Rexford, family physician at Pendleton Community Care in Franklin, West Virginia.
Excellent, thank you so much. All right, and Judith? Oh.
WVU. And Greg, that is quite a haircut.
Perfect. Jenna, you want to introduce yourself?
Sure. Hi, I'm Jenna Ward. I'm a physician assistant in family practice with Community Care of West Virginia, and I work in Rock Cave.
Awesome. Thank you, Jenna. Okay, and Lee?
Hi, my name is Leanne Levine. I'm family practice. I work with Valley Health in Huntington, West Virginia.
Great, thank you. All right, and then Lee Cochran?
Hi, can you hear me okay?
Yeah, we can.
Okay, I am Parkersburg. I'm a nurse case manager in population health with WV Medicine.
Great, thank you for joining today. All right, so Ellie, do you want to introduce yourself at the ECHO Institute?
Absolutely. Hi, everybody. My name is Ellie Cordova. I'm the replication manager here at the ECHO Institute. Super excited just to observe today. Thank you for letting us join.
Hello, everybody. My name is Saul Hernandez, and I'm the program manager for the viral hepatitis projects here at Project ECHO. It's good to be with you today.
Great. Thank you both for joining. All right. And then Crystal at the ECHO Institute.
Hi, everyone. My name is Crystal Morales, and I'm an account representative here at the ECHO Institute, here to observe, and thanks for joining us.
And hi, my name is Paulina Deming. I'm with the ECHO Institute. I'm I'm the assistant director for the viral hepatitis programs.
Awesome. Thank you both. I do anticipate some more people showing up, but we're going to introduce ourselves, and then we should have John and Kaylee as well. So I'm Caitlin Ettinger, one of the Project ECHO coordinators here.
Hi, I'm Mitra Motasham. I'm also Project ECHO coordinator.
Hi, my name is Rachel Mitchell. I'm one of the pharmacists in the specialty pharmacy.
Hi, I'm Dalton Rutter, and I'm a fourth-year pharmacy student with Rachel.
Perfect. Great. So we do have two cases prepared. Before we get started, does anybody have any questions that you've seen this week you wanted to bring up? No? All right. So Leanne, do you mind to present your case first? Is that okay?
Fine.
Awesome.
I work also in the recovery clinic here with Valley as well as primary care. And this is a recovery patient of mine. He's a 30-year-old male patient, excuse me, that was first seen in our clinic on February 22nd, 2019. And he has a history of pain pill abuse since the age of 15 and started with heroin use at age 21. My question is, he has type 1A. His first reading for his RNA viral load was 222 when he entered the program. It is 1,130,000. And then we repeated it 6 months later, and November 6, 2019, and it's 542,000. Like I said, his type is 1A, Hep B, HIV negative, liver enzymes slightly elevated. They were repeated on 11/6, and his AST was 175, and his ALT was 168. He's doing great in recovery currently, and I see him weekly. He's still in phase 1 of our MAP program. Now, the question is, we have had him scheduled multiple times for a hepatic liver ultrasound. And as everyone knows, the compliance trying to get patients to go to get anything outside of our office done is kind of...
Leanne, hey, I hate to interrupt you. Your voice will be really, we can hear it perfectly for a second and then it goes away. I don't know if something maybe is blocking the speaker just there. Sorry, I didn't want to.
Okay, that's okay. Can you hear me okay right now?
We could when you started out talking.
Okay, well, so let me just sum it up real quick. 30-year-old male, first onset with pain pills at age 15, started heroin at 21. I saw him in our recovery clinic for the first time February 22nd. He's a type 1A for his genotype. His RNA viral load on 222 at the time of his entrance into the program was 1,130,000, and the repeat 6 months later in 11/6 was 542,000. His ALT and AST is slightly elevated. His AST is 175, his ALT is 168, and that's of November of this year. And at the compliance, he comes weekly. He's still in phase 1. Excuse me. He is doing well in the recovery program. However, we cannot get him to go for a liver ultrasound. He has rescheduled multiple times. We've had multiple attempts trying to get him to have a liver ultrasound. So that's our dilemma with trying to get the Hep C treatment started.
I'm going to briefly recap because we are still having just a little bit of trouble hearing you. If I misrepresent anything, please just give me the hands up and we'll definitely discuss it further.
Okay.
So I am going to share the document that you sent me that has way more information than what I just presented to you guys. So you can kind of see how the labs changed. Give me 1 second to get there. So let's see. This was 11/6, which is one of the things now, and he's in your MAT program currently. That's how you found him.
Yes, that's correct. And that's his second level. He had one previously at the entrance into the program in February.
Right, and I believe that one's just a little bit down here. Yeah. So this was the initial one, everybody, and then the other one was done just last month. You guys want to get his hepatitis C under control, but he hasn't come back every time. Is that correct?
But no, he's coming weekly for the MAP program. So he's coming weekly to be seen through our phase 1 medical assisted treatment and our recovery program. However, he will not, we don't have ultrasound on site. So
Okay.
he will not go off site to get the ultrasound. And we have scheduled this, probably 8 to 10 times, and he just no shows. And I feel, he's doing well in recovery. We've had clean drug screens. And I feel since we have him and he's coming weekly, that we would like to get him started on treatment before we lose contact with him.
Certainly. All right. So I think that's a wonderful overview, and thank you so much, Leanne. I'm so glad that you were able to come and present today for us. So I'm going to ask for questions, comments, and impressions from the group before I turn it over to everybody in the hub.
So I really could not hear Leanne at all. So the last piece is he started treatment and hasn't come back, or he hasn't come back to start treatment?
No, he is in the Suboxone program. So he is getting Suboxone. He's in phase 1, which means he comes weekly to groups. He comes weekly to see me as a management provider, and he has individuals twice a month. So he's still in the phase 1 until end of February, where he will be qualified to go to phase 2, which he will be seen bi-weekly. But we do not have an ultrasound in our office, so that would require him to go off-site to the hospital, and he's not being compliant to follow through on the ultrasound.
Right. Dr. Feinberg, I hope you heard, he doesn't have an ultrasound because he isn't being compliant about getting one off-site. He is only returning because he is a part of their established clinic now. And so he'll see Dr. Levine and he'll see their MAT program, but he won't go anywhere else. So they don't want to lose him to follow-up as a hepatitis C patient, but they don't have that ultrasound for him.
Okay, thank you.
Great. Greg,
Is there a fibrosis score, did you say? I might have missed that. Was there a fibro score?
No.
Okay. That might be a better thing because you could do that's a non-invasive test.
Right.
He doesn't go any place. You could just do a blood test to give you an idea. Do you, Leanne, have a sense? I know this is something I run into. Like I get really enthusiastic about treating people's hepatitis C, and then I kind of sometimes forget to try to figure out how enthusiastic my patient is about treating their hepatitis C. Does he have a lot of like, does he want to get rid of this and get cured and get healthy and that sort of stuff?
Yes, he has 3 children. The 4th is, he just found out they're pregnant with the 4th.
I see.
He is very willing to go. Transportation is an issue. And like I said, sometimes with these patients, you know, they know us, they're familiar, they're comfortable, but to say they have to go to the hospital for a further study, we lose a lot that way.
Yeah, if you were to get that test, and at least in my mind, if he probably doesn't have a whole lot of fibro really. I mean, just his age and risk factors and that sort of thing. If that turns out to be the case, at least in my mind, the ultrasound becomes a lot less necessary. It's a good idea to get that to rule out other sorts of badness. Big, ugly looking, or a small, ugly looking liver, or a big, ugly looking fatty liver, or something like that. But beyond that, if you don't have any other reason, I can't imagine there would be a good indication to withhold treatment from a willing patient, especially like him. I mean, with a genotype of 1A, I mean, he should be very curable. That's great.
Right. That's one of the easier treatments.
did anybody else have any questions or comments about anything surrounding this?
Leanne, is transportation the main reason that he won't go get the ultrasound done? Have you discussed it with him?
Yes, we have discussed it. He keeps telling us he's going to reschedule. We offer bus passes. It's common for our practice. They'll come to our office. Like I said, everyone, the counselors, the med manager providers, we're all, the advocates are all in one building. But if you ask them to go, outside to a hospital, they just don't follow up.
Interesting.
So, Leanne, hey, this is John Gilfuss, one of the infection docs here at Ruby. Can you hear me okay?
Yes.
So, and forgive me, I walked in about 2 minutes late. So I missed your introduction, and I know you're new to us. So thanks for coming, number one, and presenting a patient. And are you an MAT provider? Did I hear you correctly?
Yes, I'm family practice, and I'm also do medical assisted treatment. I'm a family practitioner with Valley Health here in Huntington, West Virginia.
Boy, that's such a tremendous, so my compliments. I think this is our goal long term, is to have more people who are actually MAT providers to also be people who will be willing to write hepatitis C antiviral medications. So my compliments. You are ahead of the curve and right where we're hoping our whole state will go. So that's number one. So
thank you.
Couple things that come into play in a patient's case like this. The medications are quite simple nowadays, but they're not quite at the level of just prescribe and forget. And to get to make sure the patient is an appropriate treatment candidate, I think Dr. Peters really hit on a good fact, is getting a sense of the patient's motivation. It sounds like this patient keeps his appointments for at least seeing you and has expressed interest in treatment. So that's number one. And number two is sort of to try to get a sense. You've gotten a sense that we're trying to assess how much liver damage has been done. You know, first and foremost, the most important thing almost across the board from that perspective is how long the infection has been present. Do we know when his risk factors began? And so we can have an estimate at least of worst case scenario of when he could have acquired his hepatitis.
He started with pain pills age 15 and heroin at age 21.
21, okay. So maybe a 10-year head start with at worst for this. So again, natural history studies would tell us that we're probably still early on. One of the, and I'm going to agree with Dr. Peters that the ultrasound does not really tell us a lot of information as a standalone modality unless the patient has cirrhotic architecture. So if it's a small nodular liver demonstrating sort of reversal of flow of some of the portal vein, et cetera, in there, you a lot of times don't get a ton from just ultrasound itself. You will hear us mention these sessions a lot, an ultrasound modality known as elastography. If you're familiar with that, it's certain centers have elastography. I know down in your neck of the woods, we Dr. Tierney has a elastography machine somewhat close to you, but there are certain centers around the state, and what this does is gives extra information besides just anatomic architecture. It gives a sense of stiffness of the liver, and stiffness will correlate with fibrosis or scar tissue. And remember, when you talk about hepatitis C and the risks therein of progression to chronic liver disease, it's really fibrosis or scar tissue. So Greg, Dr. Peters had mentioned a fibro test, which is serum biomarkers. You can order it just as that. You can order FibroSure or fibro test, and it's a blood test that'll give you a score that will rank them on the fibrosis scale from no fibrosis all the way to cirrhosis. And then one of the simplest ways is just getting a CBC. And I didn't see that we have a CBC in his information, but if you have that.
We do have a CBC.
Okay.
Well, I might not just have it right in front of me. Let me see if I can pull that up for you.
Sure. And the most important components of his CBC are the platelet count from a liver disease standpoint.
Are 198.
198. Okay, very good. And is his white blood cell count okay?
7.3. And
okay.
H&H is 15.5 and 44.
Okay, so sometimes if people have really progressed liver disease, you'll see a relative leukopenia and then significant thrombocytopenia. Hard to see yourself on someone with cirrhosis with a platelet count of almost 200,000. So with other reasons for it. So everything here is telling us, and by the way, there's a little score that, and I think we restart our didactic series in January, where we're going to start from like square one of how to assess patients for the first time. But there's one of the cheap and easy fibrosis assessment tools is called the APRI index. And that's just something you can look up on MedCalc or something, but basically it's a little quick calculation where you just need the AST and the platelet count. And I think Kaylee's probably, are you doing, I thought you were.
I've started to, but I
here,
don't have a upper limit reference for AST.
I'm going to give you an estimate of what it is.
We'll need her.
You need the platelets again, 198.
True.
Just calculating briefly.
I'm calculating real briefly, but it doesn't look like the APRI will probably be high. So this is another marker. We'll go how to use this in January more in detail, but everything here is saying that the patient probably doesn't have significant scar tissue, which is all good, and in general is one of the factors we look at when we try to prognosticate where the patient is in terms of urgency of treatment, and also long-term follow-up if they're going to be at risk of complications of Hep C. Right. We sometimes do use it as well when we decide how long to treat people. depending upon whichever drug we choose. So you'll often hear us using this fibrosis assessment as a, information for the patient, but also information that lets us pick correct dosage and correct drug treatment. So while we don't have all that information for this patient, I feel fairly confident that they don't have cirrhosis just with that CBC. And I think we could pick a therapeutic. The only thing that we would need is a med list as well. So Hep C.
I have the med list if you need the med list. The only thing that he's taking currently is the Suboxone. He's on the 8+2 films.
I'm so sorry. We lost your sound for a second. I think you said Suboxone in the films, right?
Yes, he's the only current medication that he's currently taking is Suboxone 8/2 sublingual films, 1 film twice a day. He's on Prozac 40 and Truvada.
Okay.
That's not true.
Excellent. Did you
get that?
So I didn't hear, so the comment, again, this is Gil Foose here at the Maid Hub. The major things that we look for, there's obviously drug interactions I don't have memorized, but if somebody's on a big drug list, always put it through a computer system. Our pharmacists at our specialty pharmacy are really good about doing this, but the ones that seem to come up more than not is drugs related to acid suppression and statin medications. So statins, if they're on a statin or a PPI, or anti-seizure medications can sometimes be an issue. But if we don't see any of that in this patient, the major drugs available for treating genotype 1A all look like they'd be in play for this gentleman. And I don't know if anyone else has any thoughts about particular agents. What's that?
Hep B.
Oh, it's Hep B serology. Thank you. So Kaylee here at the Hub brought up a question mark about hepatitis B.
Yes, he's negative on Hep B and HIV.
Okay, good. And in particular, when we talk about hepatitis B, you're going to hear us be a little more particular with regard to saying negative. We'd like to know if not just surface antigen's negative, but if the core antibody is negative, because of some particular tricks that can happen with hepatitis B serology. Do you recollect if the hepatitis B core was ever checked to see if there was ever natural infection?
I don't believe so, because this is the first I have heard of that. In our MAT program, our clinic, our initial labs that we do and repeat, the Hep B surface antigen is all that's ever been recommended and suggested. So that's new information for me.
Yeah. So again, from when you look at Hep C co-infected patients, there are some tricky serologic patterns. Again, this is something we cover in some of the future didactics you haven't had the opportunity to benefit from yet, but you will, I promise. And checking sort of an entire, a more expanded hepatitis B serologic pattern, including core, antigen, and antibody, are all helpful so that we can further characterize risks there. But Kaylee, did you anyone else have any thoughts about therapeutics? I think this is a patient, from my perspective, I can't intelligently tell you one therapeutic would be better than another given everything, but I think the three major modalities we have nowadays is the Mavorite, the 3 pills once a day for 8 weeks, Epclusa, 1 pill once a day for 12 weeks, or Harvoni, 1 pill once a day for 8 weeks, given the viral load. And yeah, you did mention an oscillating viral load, sort of a changing over time. That's okay. Natural history of Hep C will allow you to have slight variations there of a logarithm or two, one way or another. And you can also see that for transaminases. So some days you might catch the transaminases looking better than others. There are occasional explanations for that, if there's other hepatotoxins or perhaps an alcohol binge, etc. But otherwise, it's just something we accept as part of the disease process. The only last thing I'll mention, because I'm not sure I picked this up on the presentation, was if this patient does have Medicaid, they do have sobriety restrictions. in terms of needing you to be clean for certain amounts of time. And I believe that's 3 months right now.
Yes.
So as long as he's been sober for 3 months,
Yeah.
and have a consent form signed that agrees with that,
Yes.
any of those modalities could successfully work. Other
And he has been clean.
I have a question related to that. What you're discussing now, John, was, didn't his form say that he's also currently drinking, or did I get that wrong?
No, he does not. He does not
Okay.
have alcohol in his drug system.
Dr. Feinberg, that's a good point. Again, this is Gilfus here at the Hub. So despite it not necessarily being based on clean scientific evidence, Medicaid does require this abstinence from other hepatotoxins. Again, in the old days, back in the days of interferon, there was some thought that drinking would decrease your responsiveness to interferon-based therapeutics. While we don't have evidence of that for the direct-acting antivirals, some payers like Medicaid still require a sobriety period, and I'm not sure why. Just an obstacle, so to speak, to demonstrate your, I guess, interest in your health. But we do have to play by their rules, sadly. So.
No, he does not have alcohol.
This is Rachel, the pharmacist here from the specialty pharmacy in the Hub. Something else to notice on that is the verbiage that they've used on their form for Medicaid now says that both the prescriber and the patient have to attest that they have not abused alcohol. So it's not technically full sobriety. They can't use any illicit drugs except marijuana. That's an absolute. But the form says that they have not abused alcohol. So social drinking is probably still okay.
Wow.
Thank you.
Rachel, thanks for that.
I never paid attention to that specific verbiage. That helped.
Boy, does that open it up for opportunistic interpretation. Great. Yes.
Leanne, this is Kaylee with the Hub. I just had a couple additional comments as far as treatment, which again, next year we'll start going through kind of more the treatment process as well. But as far as Medicaid's preferred formulary at this time, it's the Mavorite for 8 weeks, which Dr. Gilfus had mentioned, the Epclusa for 12. Harvoni for genotype 1A, the duration is really dependent on a few different factors. And right now, Medicaid will cover an 8-week course, but not 12 weeks. And so what could lead you to going with that shorter duration is, as he's not African-American, viral load less than 6 million, non-cirrhotic, and HIV negative. So he would technically meet those criteria as long as there are no surprises with his fibro testing. But just to make you aware of that as well, is we tend to have multiple options, but sometimes the insurance will not allow us all of those. So they'll cover 8 weeks of Harvoni. And as far as selecting a regimen, when we have as many options as we do, as in this patient, I tend to help them kind of guide which they feel would fit better with their lifestyle. So with Mavorite, it's a little higher pill burden, but it's only once a day, but they have to take it with food. And so if he's not really consistently eating or able to take it at the same time every day with food, that might not be his treatment of choice. And then Harvoni is really food independent. So if you are to choose between those two, the Harvoni is only 1 pill a day and doesn't have that food requirement. So that tends to be my go-to if we're able to do the 8 weeks.
I think for this patient, that would be a better choice for him.
Yeah.
Right. Interestingly, excuse me, there was just recently a report. It was based on a study of Mavorite that patients who wound up with the shorter course, 8 weeks rather than 12, seemed to be somewhat more adherent, suggesting that a longer course of therapy, if you had the option for doing 8 weeks of a given regimen, that might be better than doing 12. So, in this setting, for example, absent any, insurance requirements, Harvoni for 8 weeks, for example, might be preferable to Epclusa for 12.
And I would like to get him started and like to complete the course prior to him going to phase 2, where I will only see him every 2 weeks. I'd like to have him more, see him weekly and make sure he's taking it weekly, daily.
Right. But I think as Greg Peters really so nicely commented on at the beginning of the discussion of this case, it all ultimately rests on how ready is your patient to do this. And
he's very motivated. The only thing is I could not get him to do the ultrasound.
right. And if he remains active in the MAT program, it just may take him a longer time to be ready to deal with another medical issue beyond his substance use disorder. So you'll be in touch with him because he's coming back regularly for MAT, and you'll be able to discuss it with him again. We always are so eager to treat because we can cure, and there's so few things you can cure in adults. It's always such a, the charm is that you can really do that sometimes it's just as Greg said, sometimes you sort of run away with your own enthusiasm, and it's an enthusiasm the patient might not yet share, but he may get there. I think you just have to wait and be persistent.
Well, he's ready. Like I said, he's very dedicated to his recovery. He's doing well in the MAT program. We discussed the Truvada. The prep when it came out, he's doing great taking that daily. So I feel like he would do well, with the treatment.
Hey, Leanne, do you have a you work Valley's in FQHC, is it not?
Yes.
Is it, you guys have a 340B pharmacy there, like
We
a
do.
clinical pharmacist? Now, one of the things you might consider doing is actually kind of having your pharmacist make phone calls to him, like as he's in treatment, just somebody that, like another person, just so you don't have to do it, so that your nurse or just so that your staff doesn't have to do it, because it's another way for that person to maybe engage in just in a healthcare system. Kind of give him an idea that these people, this is really important. I'm taking my medicine. I'm taking it on time. It's really good adherence. We do that, and it's a really good adherence.
It works great with the patient.
Strategy, great, good.
Thank you, Greg. Thank you, Leanne. Does anybody else have any questions or comments? Leanne, did we answer all of your questions?
Yes, thank you so much.
Great.
I have one more comment. Leanne, I have one more comment. This is Kaylee again with the Hub. I just wanted to touch on vaccinations just quickly. I'm not sure if there's a protocol with your clinic, but just reminding to make sure he's vaccinated for Hep A as well as Hep B if you find that he's not already immune. And then also patients in recovery, or really any adult, I try to do their tetanus vaccine and make sure that's up to date also.
Right. We do monitor that.
Okay, perfect. Perfect. Beautiful. Thank you so much for presenting.
Thank you so much. I appreciate everyone's input.
And influenza, it's the season.
Influenza.
Everybody.
And 23 if he smokes.
Yeah.
Perfect.
Dr. Levine, hey, if you get this patient approved, let us know. We can help you with the monitoring going forward. And as you get your fibrosis assessments, we can help you determine whether or not this patient needs long-term hepatocellular carcinoma screening. But first things first, I think what you did and the decision went to get them treated have been met. So.
All right, thank you so much.
Thank you. All right, guys, we have a second case. Dr. Rexroad, are you ready? Great.
All right. This lady is a 56-year-old woman who is followed by one of my colleagues who sent her over to me last January after she had found a positive hepatitis C test on routine screening. Her risk factors, which she said were all distant, included sex with an HCV infected partner and non-professional tattoos. She's diabetic, hypertensive, has depression. She has been vaccinated for hepatitis B. Interestingly enough, she used to be a worker in a Head Start program in another county, and so she got her vaccines in the late 90s. I did not find record of hepatitis A vaccine, so we will certainly look at that. I thought we already had, so I have learned something out of all of this. But anyway, her recent PHQ, the most recent one we had was in February because we just do them once a year if they're negative, and it was indeed negative. She is a current smoker, about a pack a day. Her medication list is in front of you. She is on a fairly high dose of rosuvastatin, as you can see, keeping her cholesterol reasonably under control. She has, and let me see, I was looking at her last hemoglobin A1C was 7.6, so we're trying to get that a little bit better. But anyway, her BMI is there in front of you. She is obese. Her white blood cell count is normal. Platelets are somewhat low. Creatinine is normal. INR was last checked in the spring. It's normal. Her liver tests, I had sent this in on paper because I was hoping we could see the trajectory. Oh, good. Excellent. You put it in there. The trajectory of her liver tests over the past year or so. She has essentially gone from normal in the summer of 2018 to kind of mildly abnormal in February, about the time I was seeing her to talk about the Hep C, and then further out in July, and even further out now in another set that was just recently done. She had a normal, she had a sonography in August when my colleague, noticed the liver tests going up further. And then I think scrolling down a little bit, Caitlin, there's, there was a new CBC in October. There again, her white cell count was 4.7 and her platelets were 94. So we are beginning to see those kinds of things. I found out this morning when I was talking with my colleague about her that she had been going to a pain clinic in another part of the state from which we have never been able to extract records. So methadone was on her medication list, and we had not been doing any sort of drug testing on her because we thought she was going to the pain clinic and they would be doing it. Turns out she's not had any methadone filled in West Virginia that shows up in her PMP for over a year. So we're kind of scratching our heads and wondering if, unfortunately, she may have gone back to using something on the street, and this might be a newer Hep C infection than what she has led on, or perhaps a reinfection. So, my questions are, how do we need to jump? I think we need to treat this, but, since 2 days ago when I sent the case, the question has become, on our end, looking for any kind of new substance use. But, she had told us that all of her risk factors were in her distant past, but yet we've got a viral load that's increasing, liver functions that are getting out of hand. And, is this newer than we thought? And, after the discussion on the last case, I suspect we should be doing other things to re-image her liver, but I'm interested in everybody's thoughts on it. So that's the case in a nutshell.
Carmen, have you asked her?
I have not. As I said, she follows with, I haven't seen her since February. One of my colleagues follows her and was under the impression that she was going to the pain clinic. Now that we've found out she's not filling anything from them, that has left us with new questions.
The reason I ask you that is just because those are sometimes some of the most interesting stories that you'll get in all of medicine, and sometimes extracting the truth from people is important. I always tell people that if I have not yet earned your complete trust, please give me more time to try to do that. And that actually coaxes people into just telling the truth, usually pretty well. Actually, it kind of does so in kind of a non-accusatory sort of way. So Yeah, I'd be interested to hear kind of what that is too. I wouldn't be the least bit surprised if this lady has hepatitis C and NASH, though. Like, I would be the other. I mean, she may just have some fat that's got her liver all inflamed and irritated. If she's drinking Mountain Dew in addition to it, like that could do it. If she's just got an already kind of diseased liver. But that lady's liver numbers actually make me kind of nervous, particularly with her platelets a little on the low side. And
well, Greg, she sees Laura Nolf. I think you and Laura are acquainted. So.
I did know Laura Nolf. Yeah, I did know Laura back in the day. That's right. Yeah. Man, I hadn't thought about Laura Nolf in forever. That's really something. Wow. Yeah,
so I'll tell her that you said she's got some new questions to ask.
She was chief resident when I was a medical student, actually. But I do remember Laura Nolf. That's really neat.
Yeah.
What I'm trying to remember was, what was her albumin? Was it normal?
It's a little low.
I thought it was low, but I don't remember.
2.9.
It's 2.9.
So, the other possibility, of course, is just what Dr. Gilfus said a few paragraphs ago, which is that the change in her hepatocellular enzymes and the change in her viral load may just be part of the natural variation that you see day to day and week to week in people with chronic hepatitis C. Could she be reinfected or superinfected? I guess she could be if you did a new test. It's only really going to help you if it's something other than 1A. Which is still the most common genotype here in West Virginia. Although, between 2 and 3, that's probably a third of our patients. But I'm not convinced. I don't think we have enough evidence here. I'm not convinced that this is a new or reinfected or superinfected individual. I think Greg hit it on the head when he said, have I earned your complete trust? I think this person's social and behavioral situation really needs to be sorted out. Is she using, so is she at risk for getting hepatitis C again, without access to syringe services? I mean, those are concerns. And is she interested in treatment? I missed that. I might have missed that part, Dr. Rexroth, in the beginning, but is she seeking treatment, or this is your colleague is?
I think Dr. Nolf is probably seeking treatment on her behalf, but she is certainly compliant about coming in about her diabetes and getting her lab work done. And obviously she's taking her cholesterol medication and taking her diabetes medication. So I believe she's someone who would go along with treatment.
Well, then, given the change in West Virginia Medicaid requirements, I don't remember what her insurance was, but if it is Medicaid, yeah, since most people, that is what it is. If it is Medicaid, then as of October 1st, right, it was 3 months of sobriety, any fibrosis score, so no restriction. And I think the key thing here, it's not just even a matter of getting the medication, but having her do well long-term is whether she is currently using or not, whether that, exists as a threat to her long-term health outcomes. I don't know, John and Kaylee, what do you think?
Dr. Rexroth, this is Kaylee. I'm just going to touch on, aside from, sorting out her potential substance abuse or other behaviors, I just wanted to more so focus on the transaminitis. Certainly what Dr. Feinberg says, it's probably not an acute or reinfection or superinfection, but we tend to not see progressively increasing or progressively worsening transaminitis over a period of time. We may see it peak really high if there's a new infection and then start to trend down, but hers seems to just over the past year, basically, just be really steadily increasing, which certainly could also be a NASH component as well. But the rosuvastatin also, I just wonder how long she's been on it and at that dose, if that may be a cofactor also as contributing to her transaminitis. And then, you know, her non-invasive markers as far as her FibroSure, and then even the ultrasound doesn't seem to suggest any advanced fibrosis. But when we calculate her APRI, FIB4, you know, both of those numbers are elevated given her platelets and low platelets and her elevated transaminases. So I wonder if, you know, with her obesity, maybe these aren't very accurate as far as detecting how much underlying fibrosis there is. She's postmenopausal, so she's at a higher rate of progression. She also has, you know, again, multiple other factors that can contribute in addition to her NASH, or to her fatty liver as well, and potentially NASH. So, you know, as long as you are feeling comfortable with treating your Hep C, I would certainly err to do that sooner than later. And it seems like you're pretty confident she's compliant. Do you have any thoughts otherwise on that?
Yeah, I'm going to chime in a little bit. I'm Jean. I work in hepatology here at the Hub. I would be very suspicious if this lady is using some kind of either alcohol, some other underlying drug use, just because her AST is higher than the ALT on the most recent lab results. I would be very suspicious that she's cirrhotic. Her albumin is very low. Her platelets are low. Whether she has NASH or NAFLD is probably not necessarily important, one or the other, but I think she has some kind of fatty liver underlying on top of this hepatitis C and probable drug use as well. The rovastatin, I wouldn't take her off of that at all. I think that the likelihood of a DILI impact on the liver at this point is less of a likelihood than protecting her from risk factors for cardiac and stroke moving forward, given her diabetes and high blood pressure and dyslipidemia and obesity. So I think she probably has a lot of things going on, but I would be very suspicious that she's cirrhotic. Now, she can have low platelets just from being a smoker for a long time. She can have low platelets just from, you know, diffuse fatty infiltration, but I would be very suspicious of cirrhosis just from the albumin levels.
Okay.
Gilfu's here, though. Thank you for the input. Yeah. Remember, if we're going to talk about at the level of the ECHO program or at the level of being in the community deciding to treat a cirrhotic patient, the most important question is, are they compensated or decompensated? Because remember, we don't want to consider treating people on our own who are decompensated. And so I guess to ask that question, is there anything in her history of encephalopathy, ascites, GI bleeding that could have been varice origin, anything like that, any history that would suggest any decompensation of her liver disease in the past?
Not to my knowledge. I'm not seeing anything scrolling at her history.
For all reasons we cited above, I think treating her sooner is a great idea. I think you can feel confident to do so. And you know, some of the other benefits to do so, remember, you mentioned her A1C is 7.6. Remember, there's this weird relationship between diabetes and Hep C, where you may see improvement in glycemic control by decreasing her by getting her viral load undetectable, and even cardiovascular disease. So we're assessing her as a postmenopausal 56-year-old obese person with diabetes and saying you're at risk of cardiovascular disease, and modifying that as we can. But remember, treating her Hep C will also potentially modify her risk for cardiovascular disease. One thing I will mention is, while we, from some standpoints, would love to keep her on a statin, I'm going to need our pharmacist here. But in my mind, Crestor is probably one of the more challenging ones to come up with a regimen to treat with. So, Rachel, do you mind if I turn that over to you? Is there a statin that's better for you? So in general, Crestor is going to interact with both Mavorite and Epclusa, and I believe even Harvoni. So Rachel, thoughts on that one?
Yeah, this is Rachel. the problem with these, so the high intensity statins that we use for those patients that really need them are going to be limited in dose or totally contraindicated for a lot of these medications. So for the Crestor for these, so if you were leaning towards like a Mavorite, you would have to limit the dose to 5 milligrams of the Crestor or rosuvastatin for those. And even if you wanted to change it, depending on you know, what her insurance is going to cover, even something like atorvastatin is going to have those dose limitations. Atorvastatin is actually contraindicated with Mavorite, so you can't use that at all in that regimen. And again, limited to a smaller, like 10 milligram dose for Harvoni and Epclusa. So usually what we recommend is one of the more water-soluble kind of statins like pravastatin. Obviously, you're not going to get that high-intensity dose with that you might need, but since it's a shorter duration of treatment, usually it's okay from most of the cardiologists that we talk to, just to kind of bridge them so they're still getting their statin and still having that efficacy with something like pravastatin until they're done with their treatment. And then as they're done, because these have relatively short half-lives, they can immediately switch and go back to their original regimen.
I really wonder about that. Actually, we might even ask somebody at some point, because it sounds like what her PCP is doing is just following those ASCVD guidelines, and it's really more of a primary prevention. And I just really wonder if that's even necessary at all, because if you were just to stop that statin completely for 8 weeks and get her treated and then go back to it, that actually might be a far simpler thing, not to mention the fact that it might just decrease kind of the hepatic load of medications passing through her liver for those 8 weeks anyway. I wonder if that's actually really necessary. Now, in a lady that maybe just had a heart attack, 90 days earlier, that would, I think, be a very different conversation. But with just primary prevention in a type 2 diabetic person with relatively reasonable glycemic control anyway, I wonder if maybe just stopping her statin for 8 weeks might not just be the simpler thing for her to do as the patient, just for what it's worth.
And that's I was thinking the same thing, although, given that the odds are pretty good that this lady has cirrhosis, it would be 12, not 8. But, it's the likelihood that 3 months off rosuvastatin is going to make that much of a difference. I'm not so convinced about that.
Especially in comparison to how fixing the hepatitis C is going to decrease the inflammation she just has in general.
Yeah. I mean, I think it is primary prevention. Her cholesterol has historically been very, very well controlled on that dose. But I think you're right, Greg, that she's just doing the primary prevention kind of thing. Our cardiologists around here are sticklers is probably too mild a term in terms of wanting everyone on the highest dose statin they can tolerate. Including 90-year-olds in the nursing home, but
yeah, which I mean, okay, that's fine, but they're cardiologists, and that's what they do, is they just think about hearts and everything. It's like, but I mean, this lady benefits, I think, greatly from the fact that I know who her PCP is, and so that's okay. Like she'll think like that. That's okay. That's all right.
Yeah, she's thinking about the whole person here, I'm sure.
Good for her.
So Dr. Rexford, Gilfus here at the Hub. I think that Kaylee had brought up earlier, giving the patient a choice of what they want to do. I think your 2 choices for this patient, or 3 choices, is really going to be, Epclusa for 12 weeks, Harvoni for 12 weeks, both of which 1 pill once a day, or Mavorite. Actually, you could technically, with the new approval now for Mavorite, you can do 8 weeks for a cirrhotic patient. So, my own, and this is I'm going to go outside the guidelines here, but more a gist or a feel. The more compensated they are, the more comfortable I feel using a protease inhibitor-based regimen. So something like Mavorite in somebody who's clinically very compensated, I'm not nervous about. So if you ever have a question that the patient may have had a decompensation event in the past, I feel more confident and comfortable with things like Epclusa and Harvoni that don't have a protease inhibitor component. As we've talked about before, those tend to be a little bit higher risk for inducing decompensation events. So, so for this lady, I think you can benefit her with 8 weeks of Mavorite or 12 weeks of either of the other 2 options, and Let's do it. And I was going to ask Jean, who's our hepatology representative here today, if you would work her up for anything else at this point, or just sort of watch and see if her transaminases get better with Hep C treatment.
If they normalize with Hep C treatment, I would probably just leave it as is. If they don't normalize, I would definitely work her up beyond that.
Okay.
Great. Any other questions, Dr. Rexford? Did we answer the questions?
I think so. Thank you.
Thank you. All right, guys, we have about 5 minutes left. We actually had some questions submitted to us via email from somebody who couldn't be here today. I don't know that we'll get to all of them, but I'm going to let Mitra read the first one and see about some ideas in the next 2 minutes.
First question was, what is the commonality of a patient who is a 38-year-old white female experiencing severe muscle and joint pain since starting Maverick? And it also mentions that she's not on a statin. So we're gonna get
It came from one of our participants. She wanted to be here today, and unfortunately, a lot of clinics are trying to shove their patients in right now before the holidays.
I have no experience with that. Skillful's here at the hub. The first question I would have had for the patient was looking for drug-drug interactions that would have made her potentially more prone to a drug toxicity, especially the statins. But I've not seen anything. It's certainly not one of the common side effects that you see to this class of medications. Sometimes sleep disturbance, sometimes some fatigue, but I don't know. So the answer to their question is I don't know. I don't think I would in and of itself stop therapy if a patient could tolerate it. I might work it up further by looking at CKs. There are many drugs that can cause CPK elevations, not just statins, and I don't know of them from direct-acting antivirals for Hep C, but I do know that other antivirals, including HIV drugs, polymerase inhibitors, et cetera, can cause CK elevations, integrase inhibitors, et cetera. So that category of antivirals can cause elevation. I would also work the patient up further from the perspective, make sure that there's not a second, we're not just associating two things that have no relationship. So making sure that there's not a elevated sed rate, any other rheumatologic milieu going on. So that's my take. I've not seen it. I don't know what you guys.
I have not seen it.
Kind of goes into the next question if you want to.
So the next one is, for someone on Maverick who gets 4 weeks labs done, at what point would you discontinue treatment? And they noted that the package insert only discussed bilirubin and physical exam.
So Gilfus here again, I'm not sure exactly what they mean. If they're talking about having a response of the viral load, there is no lack of response of viral load that I would stop the therapy absolutely at 4 weeks. Remember, you can sometimes reassess. The 4 week viral load is really assessment of adherence. And you don't take a treatment decision based upon it, but you can do a reassessment a couple weeks later to see if it's not improving at all. I'm assuming they're talking about transaminitis elevation. And again, I've not seen any decompensation or worsening or flares of hepatitis from Maverick, but there's a really defined guidelines in the package insert about when to consider cessation. And some of that comes with if you're symptomatic or asymptomatic. And I don't off the top of my head have it memorized in terms of if it's 5 or 10 or 8 times the upper limit of normal. I don't know if anyone else has it memorized or anything like that. I do know that we have an upcoming didactic that talks about monitoring of transaminases while on therapy. And there are guidelines, I should say, there's guidances in hcpguidelines.org that directly address elevated transaminases during treatment. So I guess to answer the question, I'm not sure which component they're talking about, the viral load or transaminases. And we'll get to both of those during a didactic called monitoring while on therapy.
Yeah, we'll definitely ask her to come and talk about these.
Hey, John, would you extend treatment based on that though? Like if you checked a 4 week and it was still elevated, would you still feel confident just giving them 8 weeks?
Yes. Yeah.
Dr. Peters, we've had patients that they still have detectable viremia at end of treatment, which is a little worrisome. And then SVR12 they've cleared. So some just have a delayed response. I can't explain why or who. With the question that was just proposed, I agree. I don't know what components they were looking at, but just if in the event that they were already underlying cirrhosis, that's the one thing I'm wondering is if they were asking about particularly transaminases or Billy, if they may be inducing a decompensating event. So if that were the case, then yes, I would discontinue treatment.
Yeah, there's cirrhotic.
This is Jane. I one time saw a bilirubin go up in a presumably compensated cirrhotic. The bilirubin went up to, I think it went up to 3.5, and then it climbed to 5. At that point, we discontinued it. But other than that, we continued it.
And again, Gilf is here at the hub. There are guidances on hcvguidelines.org as well as the package insert that kind of can help you.
Thank you.
Good questions.
Thank you, guys. We'll definitely ask her to come in and talk about maybe the patient she's seeing. We are at the end of the session. I wanted to let you guys know we'll send out the flyer that has all of the upcoming didactics because this is our last session of 2019. 2020 starts on the 9th, and Kaylee's going to be our first presenter for that. And then if you guys have any cases, we are accepting them over the holidays. All right.
Thanks.
Bye. Everybody have a happy
holidays.
Happy holidays. Happy New Year.
Thank you so much.
Dr. Levine.
Thank you guys so much.
Thank you.